Hello, everybody. I'd like to welcome you to our first ERKNet webinar in 2025. And I'd also like to use the chance to welcome our new attendees. There are apparently 55 new attendees this year. We're very happy to welcome you here. My name is Jens König from Münster, and today I have the great pleasure to introduce our today's expert, Professor Francesco Emma from Rome. Well, what should I say? Francesco Emma actually does not need any introduction, as most of you will know him as the presenter and moderator of several ERKNet webinars, as well as an outstanding expert for any kidney-related situation. Nevertheless, let me provide you with a few details. Professor Emma received his pediatric training in Belgium at the Catholic Hospital of Louvain. He then became a pediatric nephrologist at Boston Children's Hospital before he moved to Bambino Gesù Children's Hospital in Rome, where he was appointed head of the pediatric nephrology division in 2005. He also holds the position of coordinator for translational research and research on rare diseases at the Bambino Gesù Children's Hospital. Professor Emma authored more than 250 research articles in peer-reviewed journals and is the author of several textbook chapters, as you might know. He has served as the editor on the editor board of several scientific journals and working groups dedicated to inherited renal disorders. And above that, he's the current assistant president of the European Society of Pediatric Nephrology at the ESPN. Today, Professor Emma will talk about non-cystinosis Fanconi syndrome. Francesco, thanks so much for your time right now, and please delight us with your lecture.
Thank you very much, Jens. So thank you and welcome to all. What I'll do is that I'll switch off my camera so that you can go full screen. Do you see my slides?
Yes, we do.
Okay, so let me have a pointer here, and then okay. So what I'll do here is I'll give you a brief overview on how we see Fanconi syndrome, and I'll do this in sort of in a translational way, just going from the physiopathology to the clinic of patients with Fanconi syndrome. And this is usually one of my introductory slides when I speak about the proximal tubule. It's just to remind you that this section of the nephron is responsible for the reabsorption of virtually 70 to 80% of what is filtered in the glomerulus. And this is really massive. And just to give you an idea, this is the amount of water that a normal adult reabsorbs in the proximal tubule. And if you add up all the molecules of salt that is reabsorbed, it usually comes up to approximately 1 kilogram of salt that is reabsorbed every day by our kidneys. And as if you continue down in other substance, we reabsorb about 300 grams of bicarbonate, 200 grams of glucose, and 20 grams of phosphate. So we all have sugar in our kitchen. So picture how much this is, and you realize how much our proximal tubules have to do. And they do this thanks to these very specialized cells with this brush border, which is very pronounced, so that there is a very large reabsorbing surface, and they are extremely metabolic active. They are second to the brain and heart in terms of oxygen consumption. And you can picture this by looking at all these mitochondria that are very heavily enriched in these cells. And these cells are actually specialized, and we recognize 3 different segments. And there is a dynamic in the differentiation in these various aspects of the proximal tubule, so that the second one follows after the first one and is differentiated according to what is reabsorbed at the more in a more proximal level, and I will not expand into this. But the important thing here is that the energy comes from the hydrolysis of ATP through the sodium-potassium ATPase, and it's really the sodium gradient that drives the reabsorption of all these substances. There is no sodium chloride cotransporter in mammalians. There is one up to the amphibians, and after the amphibians in the phylogeny of species, that transport has been lost, and it's probably to allow all the sodium driving force to be used for the co-transporter reabsorption of other substances. And so implicit to this, there is the fact that these cells require a lot of energy, and that mitochondria that generate this energy are really very important. You see that sodium and water are reabsorbed in an isotonic manner, whereas you can see here the concentration in the lumen of bicarbonate, amino acid, and glucose that drops, representing here active transport. So in addition to this, we recognize over in these cells reabsorption through receptor-mediated endocytosis, and I will speak to this more later in the presentation. What is important, however, is that there is a crosstalk between these two mechanisms. The transfactorial transport, which is driven by the sodium-potassium ATPase, and mostly driven by the sodium-potassium ATPase, and the receptor-mediated endocytosis. So, for example, if this doesn't work, many of these transporters cannot be properly expressed on the surface of the cell, and the cell polarity cannot be maintained. And the same applies for the reverse. If the appropriate transporters are not expressed, then you cannot expect to have a proper polarity of the cell that will allow to appropriate trafficking inside the cell. So the Fanconi syndrome is basically a dysregulation of these processes, and it's a generalized dysregulation of these processes. And it was first described by Dr. Fanconi, and in fact, at that time, it's nearly 100 years ago, he described the patients with renal glycosuria, and then the Tony, in fact, described patients that had both rickets and glycosuria. So these patients probably really had a Fanconi syndrome. And then Debré in Paris, this was in Switzerland, in Italy, and in Paris, then described, and soon after also Guido Fanconi, also described patients that had the rickets, the glycosuria, the nephropathy, and these were really patients with Fanconi syndrome. So this is sort of a summary. It's an very old slide of mine, but I always show it because it summarizes everything. And you see here at the center the mitochondria, you see all the apical transporter, the basal adult transporter, the receptor-mediated endocytosis, you see water and chloride that go paracellularly, and here we have aquaporin 1 that is expressed, and that mediates here the uptake of water that follows the osmotic gradient. So if we now recap the various diseases that can cause here damage to the proximal tubule, we can have isolated apical transport defects. Now, these will not cause Fanconi syndrome. If your RPAT system doesn't work, you will have cystinuria. If your glucose, the SGLT2 transporter doesn't work, or you will have glycosuria, but you will not have Fanconi syndrome. If you have basolateral transporters that don't work, on the other hand, you can have a disruption of the function of the cell. For example, in lysinuric protein intolerance, in Fanconi syndrome, then you have an accumulation of substance inside the cells that will eventually disrupt the functioning of the cell. So basolateral transporter defect sometimes can cause Fanconi syndrome. You would expect that if you have transcription factors which are essential to organize all this very complicated system are mutated, that will cause a disruption of the functioning of these cells. But in fact, there are very few diseases that are related to transcription factors that will cause Fanconi syndrome. Now we'll come back to this. And to me, this is a little bit sort of surprising, but this is how it is. On the other hand, if you have a damage to your mitochondria, be that a primary mitochondrial defect or the accumulation of metabolic substances that will damage your mitochondria, then yes, you should expect that the system doesn't work and that the patients can develop Fanconi syndrome. And also here, if you have impaired receptor-mediated endocytosis, again, the cell will not function, and this will cause Fanconi syndrome, except if you have variants that will affect directly the two receptors. Now we'll get back to this again. And then let us not forget that in many cases, especially in adult nephrology or in the clinic of patients that are treated with some particular drugs, you can have acquired forms of Fanconi syndrome. Now, obviously, the younger you are, the more likely you are to have a genetic cause, but the older you are, the more likely you are to have an acquired form of Fanconi syndrome. Now, heavy metals are no longer seen. Intoxication with heavy metals at our latitudes. If they happen, usually it's because you have industrial soiling of the soil, but in some countries they may still be present. And the two most important are lead and cadmium. Outdated tetracycline, just remember this, tetracycline are very safe until they're not outdated. If there is one drug that you should never use when it's outdated, is tetracycline. What is frequent, on the other hand, although our oncologist colleagues are becoming better and they also have better drugs now, is the effect of cytotoxic agents, and it's especially ifosfamide and cisplatinum. Cisplatinum it comes back to here to the heavy metals. Heavy metals are toxic for the proximal tubular cells, and these are dose dependent, and unfortunately they're not necessarily reversible. Then we have other drugs. I will just point out to valproate. Valproate, probably because you give, when you treat someone with valproate, you probably give chronic treatment, is a case that you should pay attention to. A drug that you should pay attention to that can cause Fanconi syndrome, and then you have in adult medicine light chain nephropathy, and it's especially some variants of light chain that give a specific conformation to the light chain that will eventually crystallize inside the proximal tubular cells and disrupt the proximal tubular cells. Sometimes amyloidosis and multiple myeloma can also cause damage to proximal cells, but usually the glomerular disease is more pronounced, and the same applies to autoimmune diseases. So if we now go back to the genetic forms, we have the metabolic diseases. I'm simply mentioning here because this is a sort of a teaching lecture, galactosemia, fructose intolerance, and Wilson disease. but these will usually not present with Fanconi syndrome. They can have Fanconi syndrome, whereas sometimes tyrosinemia can present with Fanconi syndrome and mitochondrial cytopathies as well. Then, as I mentioned to you, we have the membrane transporter defect or transcription factors, and that would be the basolateral GLUT2 transporter in Fanconi-Bickel syndrome, and this really is a glycogenosis. These patients usually have hypoglycemia, liver disease, but they often have rickets. They have hypophosphaturic rickets, failure to thrive. Lysonuric protein intolerance, it's a much more pleomorphic disease. And patients can have very mild, but sometimes also very severe disease. The most severe forms are the ones that have severe immunological disorders and alveolar proteinosis. And you recognize also these patients because they really avoid proteins take. And then I mentioned to you transcription factor. There is one transcription factor variant, it's HNF4 alpha, and within this one, it's only this variant that will cause autosomal dominant Fanconi syndrome. And I'll come back to this. And then we have all the defects that are related to the intracellular trafficking. So the first two are related to variants that affect the two receptors. These are not really Fanconi syndrome, but they cause low molecular weight proteinuria. And low molecular weight proteinuria is really the common feature of all these cases. If you don't have low molecular weight proteinuria, I think it's safe to say that you don't have Fanconi syndrome. And here we find cystinosis, and which, as you know, it's a very complex disease. And this is the reason why in this lecture, we have decided to leave aside cystinosis that deserve a lecture by itself. Lower syndrome than disease are extreme. So, and then when you don't understand the cause, we usually say that it's idiopathic Fanconi syndrome, which is a very elegant way to say that we didn't understand anything. So again, mitochondrial cytopathies. Look at this picture, how many mitochondria these cells contain. If you have some experience with electron microscopy, you will recognize that this is a very metabolically active cells. So it should not come to any surprise to you that if you have a mitochondrial cytopathy that involves the kidney, patients can have Fanconi syndrome. Sometimes they have other tubular defect or some incomplete forms of Fanconi syndrome, like renal tubular acidosis, isolated hypomagnesemia, hyperaminosuria, but it's usually they do have some low molecular weight proteinuria and some more or less selective losses of other substances that are reabsorbed at the proximal tubular level. There are some very rare genetic forms that have been specifically described, like those that involve this enzyme, which I now, since many years, refuse to pronounce the name. You can read it here. And this enzyme is actually a peroxisomal enzyme. And there are some variants where this enzyme, instead of being directed towards the peroxisome, is directed towards the mitochondria, where it inserts itself in the respiratory chain and alter the functions of the mitochondria. And so it's sort of in a way an activating mutation because even heterozygous variants will be sufficient to disrupt mitochondrial function. And as you can see, it's a Fanconi syndrome, which is inherited in a dominant form, usually not very severe, but this has been reported now in several families. And then in Canada, another form of Fanconi syndrome, which is characterized by pulmonary involvement, and they tend to develop, these patients, in the long run, interstitial pulmonary fibrosis and progressively CKD. These are a number of patients. You can see the decline in GFR is due to this enzyme, and this enzyme is actually an enzyme involved in hold on a second, just here I have is it complex 1? Anyway, it's in the mitochondrial respiratory chain, and is by all means, it's a mitochondrial cytopathy. You can see this intense proliferation of abnormal mitochondria in the proximal tubular cells, and also partially here, I think this is a podocyte. So this is another form, and it's most in Nova Scotia in Canada. Now, one thing that can help you distinguishing these patients is by looking at organic acids. Now, if the mitochondria do not work, and by the way, it was complex 1 for the Canadian disease, then what happens is that you accumulate NADH in your mitochondria, and if you have an excess of NADH, you have two consequences. One is that pyruvate will not be converted into acetyl coenzyme A, and acetoacetate will be converted into hydroxybutyrate. And upstream to this, pyruvate will generate lactate. So if you look at the organic acid of these patients, very often what you will see is that you have an excess of hydroxybutyrate and pyruvate and lactate. Especially if you have a tubular disease. Sometimes, however, and importantly, if the disease is in the kidney, sometimes you don't see hyperlactacidemia. And then if you lack ATP, you also tend to find 5-oxoproline, because 5-oxoproline is the upstream metabolism of the glutathione biosynthesis. So if you don't have ATP, you cannot run the cycle, and 5-oxoproline will accumulate. And if you do electron microscopy, these are two cases of Fanconi syndrome, you see this accumulation of very abnormal mitochondria. But nowadays, you will probably just go ahead and do the genetics. So this is something you no longer do. I mentioned to you among the metabolic diseases, tyrosinemia type 1. You see, this is one of our patients with this disease that presented with rickets. And in tyrosinemia type 1, you can have a very acute form. This is a devastating form, nearly neonocongenital form. And these patients do not have Fanconi syndrome. You have a chronic form that presents later in life, but you have a subacute form where patients do develop Fanconi syndrome, and sometimes you see them because they have rickets. And as you know, these patients can develop hepatoblastoma. In the long run, they have this liver which is very dishomogeneous. If you palpate these patients, you often see, you can feel that the liver has not a smooth margin. And certainly by ultrasound, you can picture this. They have increased alpha-fetoprotein. For those of you that don't remember tyrosinemia, this is something which is very classical and typical of tyrosinemia. Obviously, they have high tyrosine, and in the urine, they have hydroxyphenylpyruvate, phenylacetate, and phenylactate. Now, why did I mention this together with the mitochondrial cytopathies? Is that it's probably related to a mitochondrial cytotoxicity. So in type 1, this is where the defect lies. So this enzyme, the phenyl acetoacetate, doesn't work. And so obviously you accumulate tyrosine, but all this chain is impaired. Type 2 and type 3 have a defect here upstream. So here, the mouse model teaches us a lot. So if you have this mutation in this gene, usually the mice die. However, and that's because they produce succinylacetone, and this is probably what is really toxic to the mitochondria. Now, if you do a double knockout and you have a mice that lacks this enzyme, so it's a tyrosinemia type 1 and 3 together, these mice have no liver and no renal disease. And this really makes you understand that the toxic metabolics are here. And this is reinforced because if to these mice you add homogentisate, which is this substance here, then they develop Fanconi syndrome. So this was a it's now more than 25 years ago, there was a very elegant demonstration that this is really what is toxic for these mice. And it's important because we can treat our patients with NTCB, this substance that blocks this enzyme. And you can see here the improvement in the Fanconi syndrome. These were some of our patients, and you can see that the TMP of a GFR increased as succinylacetone levels decrease. So it's a very nice way to go from the physiopathology to the treatment. I mentioned to you that there is this variant in the HNF4 alpha variants. Now, HNF4 alpha also causes a MODY disease, a maturity onset diabetes of the young. We recently had a survey. It's an international survey collecting patients with these variants together with treatment. And you see, just look at the percentage here. I think it's one of the largest cohort that's been assembled. These patients are premature often, but despite being premature, they have a large birth weight. So they tend to have microsomia, and they tend to have neonatal hypoglycemia in about 2/3 of cases. And then from the clinical perspective, you see that 40 to 50% of patients have failure to thrive. They can have rickets, osteomalacia, and nephrocalcinosis. They sometimes have liver and cardiac symptoms, usually mild, and some of them, when they're young, when they're adults, develop diabetes mellitus. Now, all of them, when they're all older than 10 years, have some degrees of CKD, so it's not a so benign disease. Now, let me move to the receptor-mediated endocytosis defect. And you're probably all familiar with this, but you know that we reabsorb about 5% of albumin and low molecular weight proteins by these mechanisms. The two receptors are tubulin, which requires amylase to be expressed to the cell surface, and megalin. The ligands are not exactly the same. Albumin is bound by both of them, and ApoA1, apolipoprotein A1, is actually specific, as well as IgG light chain of tubulin. And it's the spectrum of molecules reabsorbed by megalin. The bind to megalin is much larger. So what happened is that the ligand binds to the receptor. They're internalized. They migrate and diffuse to pre-lysosome, and probably it's the acidity that separate the ligand from his receptor. The receptor is recycled to the apical surface, and then the protein is then digested. And we can measure this by measuring low molecular weight proteins. And they're all markers, they're good markers. Beta-2 microglobulin is often used, although you should know that bacteria in the urine can degrade beta-2 microglobulins. And you see that even when you have some glomerular diseases, you can have some low molecular weight proteins, but it's really the magnitude of the proteinuria, which is related to low molecular weight proteins compared to albumin, that gives you the diagnosis, because you will lose some albumin, because as I mentioned to you, a little bit of the albumin is still filtered by the glomerulus, and you will find this in the urine if you don't have an appropriate reabsorption at the proximal tumor levels. Carriers, when for Dent disease, have higher levels than the normal population. Notice that this is a logarithmic scales, and you see that in glomerular disease, once you have significant involvement of the tubular interstitium, you can have a little bit of low molecular weight proteinuria, but this is not so disproportionate compared to the albuminuria as in Fanconi syndrome. So it's really the relationship of the two that will prompt you to think about a Fanconi syndrome if you have proteinuria. And you have positive dipstick, as again, because you do have albuminuria in these diseases. And here you have a cartoon where some of these diseases are depicted. Cystinosis, obviously at the level of the lysosome. Dent disease and Lowe syndrome are important for the intracellular trafficking these proteins. And Dane-Barrow and Imerslund-Grasbach and ERK syndrome, which is not illustrated here. Now, in Imerslund-Grasbach, you do have variants that affect either the amnionless or the cubulin protein. And these patients are important to find because they don't have Fanconi syndrome, but you will find them because they have massive low molecular weight proteinuria. And one of the things that they do have is they have megaloblastic anemia, because this forms the intrinsic factor complex with vitamin B12, which is necessary for the intestinal reabsorption of vitamin B12. So sometimes they have other symptoms like failure to thrive, probably maybe a little bit more prone to have some infection, maybe some very mild neurological symptoms, but honestly, most of these patients are just doing well if you recognize them and if you treat them with pharmacological doses of vitamin B12. This is a patient of us, and just simply to demonstrate, remember that I show you that apolipoprotein A1 is a ligand of cubulin. You see in the urine this loss of apolipoprotein A1. If you look retinol binding protein, this one is specific of megalin, and you see that there is no loss in the urine of these patients. You see here that cubulin and amnionless are not expressed, and you see here in the control patient reabsorption of ApoA1, not in the patients, whereas megalin is expressed and retinol binding protein is normally reabsorbed. Dane-Barrow syndrome is due to variants of megalin. This is a much more severe disease. You can see that most of these patients have this abnormal facial feature with these eyes that are separated. They tend to fall down on the edges. You see this broad nose and this flatness or bridge. One characteristic of these patients is that they have very, very severe myopia, and they can have, they usually have mental retardation, and they can also have other features, in particular sensorineural hearing losses. The other important thing is that it's a very rare condition. It's unlikely that you will find some of these patients. These are two of our siblings. Actually, they have mild phenotype because they only have a mild missense mutations, but you can see here nicely, you see megalin, which is not expressed, and you see here that they're losing retinol binding protein, which is a specific binder of megalin, as well as other low molecular weight proteinuria proteins, as you would expect with the megalin changes. Now, arthropre post-renal dysfunction cholestasis, so ERK syndrome, you may actually see these patients. They're not very frequent, and usually they come from Saudi Arabia or from Pakistan. But there are some sporadic cases, and they have these children are born with arthrogryposis, they have cholestasis, and they have a tubular dysfunction. It's a constant in these patients. Sometimes the arteriovenous may not be so severe, but you have the cholestasis and the renal Fanconi syndrome. It's a severe disease. They have, they also have deafness. They have cerebral abnormalities like degenesis or corpus callosis, and they can have a number of other conditions. And these proteins, VPS33B and VPAR, are part of a complex which is absolutely important for intracellular recycling. So we always come back to the same thing. They are in blue here, and you can see that they are important to link different endocytic vesicles to one another, and they are crucial for the apical recycling pathway, but also for, in general, the intracellular trafficking in these cells. So it should not come to a surprise that when you have this thyroid defect, your receptor-mediated endocytosis doesn't work. And recently, there are a couple of other diseases that have been described. This one is this factor, EHD1, and this protein is important for the fission of the endocytic tubule. So when you have this endocytic vesicle, they somehow needs to fuse, but also to separate in order to fuse with other compartments. And these patients have Fanconi syndrome. One thing, by the way, that I show you is that in this Fanconi syndrome, if you do a DMSA scan, in all of these that I've shown you that have low molecular weight proteinuria, the DMSA scan will show you a low grade of uptake. And this is due to the fact that DMSA is reabsorbed through receptor-mediated endocytosis. So these patients also have deafness, and then more recently, this case has been described. These are mostly single cases, one or two cases with a variance in this protein. And again, this protein is in fact localized to early endocytic compartment, and you can see that the endocytic activity of these cells is impaired, and again, the clathrin vesicles are not formed normally in patients, in these two patients with this variant. So again, it all points to this defect. I'm nearly done. When you have a global dysfunction of the cells, be they cystinosis, lower disease, Dent disease, or acquired Sjogren's syndrome, you can see that the expression of megalin and tubulin is abnormal. So it should not come to a surprise that these patients have low molecular weight proteinuria. As you can see, they can have rickets because of hypophosphatemic rickets. And we have phenocopies here of same disease. And you know that Dent-1 disease is caused by the variance in this chloride channel, which at least in part impairs the acidification of this free lysosome, but it's probably more complex than this. OCRL1 is a defect where you have the 4,5 phosphatidylinositol phosphatase, which is variant and which is mutated, and this phosphatase is absolutely critical for the intracellular trafficking. You have clustering of clathrin vesicles in actin in an actin network beside the cell membrane. The trafficking to and from the Golgi and to the lysosome is also impaired. We have here common phenotypes. So if you compare Dent-1 and Dent-2 disease, all of them have low molecular weight proteinuria, but you see that nephrocalcinosis is usually more pronounced in Dent-1, hyperuricemia more in Dent-2. Notice that glycosuria is very rare in patients with OCRL1 variants, and this is something we still don't quite understand why. It's more frequently observed in Dent-1 disease, and failure to thrive is usually more severe in Dent 2. And Dent 2 patients can also have some mild intellectual disability, and they also have, nearly all of them, increased LDH and CPK, similar to Lowe syndrome. And when you compare Lowe syndrome, and they have a progression of CKD, which is probably a little bit slower than Lowe syndrome. If you compare Lowe syndrome, these all have OCR1 variants, but we do see that they have CPK and LDH elevated in most of them, although these, the Dent 2 phenotype is milder. They all have low molecular weight proteinuria. Notice that glycosuria is infrequent, but usually if you compare cataract, intellectual disability, and all the other features of Lowe syndrome, which is a very severe disease with congenital cataract, very severe intellectual impairment, growth retardation, and the tubulopathy, it's actually much milder in Bent disease. In some cases, it's not easy to classify patients as having one or the other disease because they really have an intermediate phenotype, but usually you can cross the patients in one or the other phenotype. And probably Lowe disease, again, progresses a little bit faster. This, I think it's my last slide, just to simply that we now understand better what happens, although not completely. So in Dent, this is the OCRL gene. It has different domain. This is the phosphatase domain, so it's around here between exon 8 and exon 15, which is responsible for the enzyme activity. The beginning of the molecule and the end of the molecule binds to clathrin. So they're very active in the endocytic complex, and this part of the molecule binds small RAP-GTPases. And you can see here that the Dent 2 disease variants are clustered in the first 7 exons, unless they are missense mutant variants. If they are missense mutant variants, they can be also in the other domains of the protein, where in Lowe syndrome, you always have variants at this level. One possibility is that you have a second ATG starting codon here, so you could have a partial protein that still has some enzymatic activity if you have variants that are clustered here in the beginning, but it's actually probably not so simple. And with this, I'm done. Let me just tell you that the next webinar will be by Nicole van der Kar, and she will talk to us about Streptococcus pneumonia HUS. And then we will have in February another webinar by Dagmara Zuzalka from DANS, which is about optimizing PD with a focus on ecodextrin. And you can also follow ERKNet and all the webinars and all the teaching activities by looking at the ERKNet website. And if you had the time with your cell phone to capture one of these QR codes, you can do so. Thank you very much. I'm going to turn off my screen, my camera. Can you see me now?
Yes, okay. We can. Thanks a lot, Francesca, for this fantastic presentation on, this indeed very complex topic. And I'm afraid I have to apologize as well, because I've once again forgot to motivate you guys to put questions in the question box at the beginning of this talk. So I can't see any questions yet, but I will give you the chance again to put questions to Francesco in the question box, and I will read them out. And in the meanwhile, I will start with the first question, if I may. Obviously, Francesco, when we observe renal Fanconi syndrome, we have to exclude secondary causes and cystinosis-related Fanconi syndrome first. But when we do that, out of your experience, how high are the chances that we will find a genetic cause in the rest of these patients?
So, so the point here is that, let me just answer this indirectly. So if you have a really full-blown, massive Fanconi syndrome, not this, so really severe cases. Over the past 20 years, I have one patient that I could not, where I could not identify a cause. Now, in some patients, I don't have a genetic cause, but I have clear evidence that have a mitochondrial disease. For the other patients, I've always found a cause, and most of them have Fanconi syndrome, or they had a clear toxic effect. They were, it's so at the end. I mean, in 2025, it's becoming increasingly rare to have patients where you cannot trace them back to a cause. And the other thing is that these patients are very rare. So by definition, it will be very rare that you will find a patient like this that doesn't have a genetic disease. I think 80% of these, if they're young, they have cystinosis.
Okay, that's quite a motivation. Thanks a lot. And maybe a second question as well. You've shown for some of the diseases, particularly for HNF4 alpha, for this cohort as well, that most of these patients, the HNF4 alpha patients, progress to some grade of CKD. How about the other causes? Is that a general phenomenon for all of the renal Fanconi syndrome patients?
So again, it depends about the magnitude. If you have a full-blown Fanconi syndrome that has the heavy low molecular weight proteinuria, clear proximal tubule dysfunction, these patients that you need to treat with alkali, with phosphate supplements, they will all progress eventually. The cystinosis is different because they progress more rapidly, and usually they progress within 2 or 3 decades. If you look at Lowe syndrome, if you look at patients with HNF4 alpha, if you look at Dent 2 disease, I mean, they usually go on dialysis when they're in their 20s or 30s, typically. Whereas a cystinotic patient, which is not treated, will be on dialysis at 10 years of age. But the rate of progression is actually fairly similar with all these diseases.
Okay. And maybe one more question regarding these cases that are related to mitochondrial function that is disturbed. Is there anything as a therapeutic approach apart from replacing what is getting lost by urine?
No. So you know, people have tried to give riboflavin, to give antioxidant, to give, you know, it's actually rare that CoQ10 biosynthesis defect gives you tubular defect. They usually give glomerular defect if they give something in the kidney. But you can try to give some ubiquinone, ibidinone, carnitine, but at the end of the day, I think it's fair to say that we don't have appropriate treatments for these patients.
All right, I have another look at the question box. Unfortunately, I can't see any more questions, so.
But that's fine, you know.
Absolutely. Absolutely. All stunned and all questions answered, apparently. So in that case, I once again would like to thank you for this presentation and for your time. And hope to see everybody again in 2 weeks' time at the next webinar. Thank you, Francesco.
Bye-bye.
Thank you both. Bye. Have a nice
Bye.
evening.